Sir here, welcome to the basic Phacoemulsification course organized by Ophthalmology Department, Cairo University. I'm going to share with you some of the important points when you are starting or getting your way into phacoemulsification. The advices are observe a lot, read a lot, assist a lot. You have to learn how to sit, how to use the microscope, how to use the machine and foot switch, understand the techniques, the rules of the techniques, different techniques. And remember, Capsulorhexis is crucial in improving or making your technique safe. Adjusting the way you sit, you should have the foot switch of the phaco machine and the microscope from the beginning under control. You don't use it in the middle of the surgery. Don't look for it in the middle of the surgery. This is very important to make sure how you sit comfortably, to make your concentration focus on the surgery itself. You have to know that phacoemulsification is footwork. So in the time you are preparing yourself to start phacoemulsification, you should spend some good time in learning how to use the foot switch, how to learn the sounds that are created, which is the feedback of which position you are. This is very important because this is how you are going to maneuver inside the eye. So your control of the foot switch is really very crucial, and you should spend some time before starting your surgeries in getting this sense. All phaco machines have essentially three positions, where in one there is irrigation, in position 2 there is irrigation aspiration, 3 is added on this is ultrasound, and each of the last two positions have a range, and this range you can control with the foot switch, where you can increase the vacuum or decrease the vacuum. You can use all the ultrasound you preset or part of the ultrasound according to the situation. And of course, you should know the settings in the machine, because this is what you're going to order the nurse to put for you. This is the main things that you should learn before you start. So for me, I use in almost more than 95 of my cases topical anesthesia, and topical anesthesia is very helpful in many aspects. But the crucial step in topical anesthesia is that all the team should communicate with the patient, telling him every step from disinfection till the ion insertion to speculum insertion. Everything you do, you should tell the patient. Once you do this, then the patient will be cooperative and the pain threshold will increase markedly. Of course, you can use, plus the eye drops, you can use lidocaine gel, or in some patients you need to have a systemic sedation, mild systemic sedation. Let's move to the technique. One of the crucial steps is Capsulorhexis. This should be reproducible, and knowing the rules, you can improve gradually, and you can have a very steep learning curve, which is important. The Capsulorhexis helps you to have a safer surgery in the learning period. You can do the Capsulorhexis with forceps or needle, and you should learn both. Some people prefer one of these, but the most important thing is that you should understand there are 4 golden rules to make your Capsulorhexis reproducible. 1 is having a deep anterior chamber, 2 holding near the tearing edge, 3 bringing the flap to the center, 4 moving every 2 clock hours to be reproducible and systematic. Let's see in a slow motion the application of this rules. This is filling the anterior chamber with viscoelastic, so you can control only with the forceps the tearing of the edge of the rhexis, because you equalize the pressure in front and behind the posterior capsule, regrasping near the tearing edge, and bringing the flap to the center to avoid extension. Moving every 2 clock hours helps you to reproduce the technique, and in this way you can control the size and the shape of the Capsulorhexis. Of course, as you can see, high magnification helps markedly to do this. Second step, which is important, is Hydrodissection, which help you to rotate the nucleus wherever you want to, so as to you are able with this stiff phaco tip to remove the nucleus. The rules of hydrodissection is important to understand. You go with the cannula, 27 gauge here, inject the fluid. The most important thing is that you see the wave of the fluid passing by the lens and helping it to cross over. Once it crosses over, as you see here, it means that this lens is properly hydrodissected. You don't need to inject too many times. You have to see and understand what's your end point. In some cases like this, and for beginners, you can do hydrodelineation as well, delineating the nucleus and having this nice golden ring, and this is by injecting fluid into the nucleus itself. These are very simple but important maneuvers that you should do in the right way to avoid mishaps like improper hydrodissection, or you're using too much fluid and you can induce rupture of the posterior capsule. Let's see, the rules of the emulsification of the nucleus. You have to know that we work in two steps. One is we are trying to weaken the nucleus by doing a groove, and in this stage we need high power but low vacuum or no vacuum, and it's the lower edge of the phaco tip which helps you doing the groove. On the other hand, while removing the nucleus itself, you need the vacuum with little power. Now this is the groove cracking, and with good hydrodissection you can rotate easily the nucleus, and we can see the groove and the depth. We can see it in a slow motion. You shave the cortex just to see, and the groove itself should be within the premises of the capsulorhexis. You need it deep but not long. Once you are deep enough, with the help of the phaco tip and the chopper, this is a nucleus splitter which I use for vertical chopping. It's a very useful instrument. Once you go deep enough, resting the tip in the floor, as you can see, you can easily crack the nucleus. You can make sure it's 180 all through crack, or just part of the nucleus is cracked. Then all what you need to do to split it is your aim is to remove part of this part of the, just any small piece. Once you break the continuity of the nucleus, then everything flows easily. Don't jump from one step to another, because this will make things difficult. You can see here in slow motion, you embed the tip. That's why the exposure of the tip is very important. And here you are using the vertical chopping, which is a very useful technique. It's like cutting a piece of steak by fork and knife. The fork here is the phaco tip. Use little ultrasound to embed into the nucleus, and then the knife is the chopper, where you slice it into smaller and smaller pieces. The harder the nucleus, the more you need to embed to fix better the nucleus, so you are able to slice it into smaller and smaller pieces. This is the basic principle for this vertical chopping. The nice thing about vertical chopping, you can do it always under vision, with even with a small pupil and hard nuclei. You don't have to reach to the equator. So it's a very handy, useful technique that you can use in all types of cataracts and sizes of pupil. And again, as you can see, you are holding the vacuum. This is the main thing. Ultrasound just to hold, to embed into the nucleus, the fork into the steak, and this with vacuum will hold the piece, and you can, as you can see, slice it into smaller and smaller pieces that can be easily aspirated. The idea here is that we want to use essentially vacuum to remove the nucleus, and we use ultrasound, which is minimal, just to help you to aspirate what you have emulsified. This gives you the least energy subjected to the corneal endothelium, and consequently best post-operative results. Let's go through the technique again. in unedited movies. This is because I use topical anesthesia, I need to fix, and I don't want to hurt the conjunctiva, so I fix with the super blade. I make the incision and then the paracentesis. I use the super blade because it makes more beveled and I can control the size. So I decrease the incidence of iris prolapse from the paracentesis. Then you have to fill the anterior chamber with viscoelastic. In topical anesthesia, you can ask the patient to look to the light of the microscope. I did already open a slit into the capsule with the super blade, and then I can move following the rules in a deep anterior chamber. Always observe the wound edge, because with the rexes you can depress the wound and lose some of the viscoelastic. If you lose some of the viscoelastic, then you break rule number 1 and the capsulorhexis can extend. This is followed by hydrodissection, making sure that the wave passes, nucleus rotates. Then you will go with the Phacotip. I prefer going with the Phacotip with the infusion on. This helps you going into the eye easier without holding. Try not to hold the epithelium or the wound. And while rotating during your entry, it makes it easier. Then the chopper will help you to manipulate the eye and fix it wherever you want. You can see again the exposure. The side pores of the silicone sleeve usually should be pointing to the sides, and always observe them. You can see here, this is a form of doing a short groove and then vertical chopping. You depend on vacuum, little ultrasound. Only during the groove you need some power. But here you need to occlude the tip to aspirate and to reach the maximum vacuum you have already set. And this, of course, you can exchange, increase or decrease according to the scenario of what's happening. And you can see with little ultrasound, you get the nucleus, hold it, and then with the chopper you slice it along the cracking lines and normal splitting lines of the nucleus. You can see the control of the Phacotip over the nucleus or nucleus fragments. It's mainly by the foot switch and how much vacuum you have put. And again, the objective is to aspirate the nucleus. You do use only ultrasound whenever it is needed. If everything coming without aspiration, without ultrasound, this is fine. Once you go out, you finish the nuclear parts. And if you did good hydrodissections, there is little cortex present. And I always prefer, once I go out with the phaco probe, I inject viscoelastic. I don't want to have a shallow anterior chamber. Moreover, this opens the leaves of the bags and facilitates the irrigation aspiration. If you have done good hydrodissection, usually the epinucleus comes out with the nucleus and the irrigation aspiration is very straightforward. You try to make sure you are not leaving any cortical material, and using the bimanual technique allows you to exchange hands, so no point is difficult. And with pointing of the irrigation to the posterior capsule, it inflates the back and makes it safer. Sometimes, even if you catch trying to remove some cells, it's important so long you control your foot switch. And then almost always there are some cells on the posterior capsule. The best thing is to try to wash them as if you have a hose cleaning dust over a corridor, for example. This is followed by inflation of the back with viscoelastic and then implantation. Here I'm implanting a one-piece hydrophobic acrylic. So the type of injector, you use both hands. So this is nice with topical anesthesia because you ask the patient to look opposite to the direction of insertion. So this gives you resistance. The hydrophobic acrylic unfolds slowly, so you can easily manipulate the lens into the capsular bag under viscoelastic. Whenever you feel the anterior chamber is shallow, just inject some viscoelastic. And then the lens unfolds nicely into the capsular bag. Make sure that the whole of both haptics are in the bag and the optic in the bag by seeing the capsulorhexis overlying the optic. And after this, you remove the viscoelastic. You don't want to leave too much of the viscoelastic to avoid postoperative increase in intraocular pressure. Sometimes you can go behind the lens to clear the viscoelastic or some of adherent lens fibers. Once you finish this, you inject or do hydration to the paracentesis and the main wound as well, because usually they get a little bit rounded. You don't want any post-operative hypotony as well, so as not to invite infection. Following this, we inject intracapsular antibiotic to avoid or to decrease the incidence of endophthalmitis. Let's have a look in another case. After the capsulorhexis, you see high magnification makes you understand well. You do hydrodissection, make sure the nucleus already is mobilized, and then you go with the phaco piece. You can see the gauges here, the infusion height, the position of the foot switch. You can see the average power used, the preset, the highest power is 30%, but actually you don't use 30%. Use according to the hardness, how much you use according to the hardness of the nucleus. Here, once I go deep, I can crack the nucleus, and then I need only to remove this very small quadrant. Once you break the continuity, it's easy. You don't have to continue the track to the other side. The most important thing I want you here to look how the tip is exposed, how much of it is exposed, how you use the vacuum after engaging the part of the nucleus. You can look to the gauges here. It's essentially vacuum. Power is used very, very, very limited in limited times. Very, very low ultrasound used. And you can see the foot switch, how it changes. Main time you are working in position number 2, which is irrigation, aspiration, and vacuum, because you want to aspirate the nucleus. Only the ultrasound comes in as buzzes. These buzzes will help you to just swallow more of the nucleus. So look to the gauges here. You see the power is rarely used, very limited, and already I put the ceiling in low power. And all this parameters helps you to protect the cornea, and also protecting the cornea by working away from the corneal endothelium. Try to work in the back or at the iris plane, not in the anterior chamber. The closer to the cornea, the more dangerous, even if you use lateral ultrasound. Here's the epinucleus. We're trying to aspirate it with the phaco piece. You can avoid this, of course. Let's look to another example. Here's another example. Again, following the rules of the capsulorhexis, pinching, holding near the tearing edge, the flap to the center, moving every 2 clock hours, until you reach the size that you want from the capsulorhexis. Then hydrodissection follows. Get some of the viscoelastic out, go under the anterior capsule to the equator, inject the fluid, make sure it passes to the other side. Once it passes to the other side, you are sure that the nucleus and the epinucleus are separated from the posterior capsule. Then you go with the phaco with infusion on, good exposure of the tip, then the nucleus splitter, Neumann splitter, shaving the superficial cortex and getting into the nucleus. This is quick vertical chop. As I said before, the main thing is using little ultrasound to embed into the nucleus, and then with the vacuum, which is usually 400 millimeters of mercury, you hold the nucleus and then chop it into smaller and smaller pieces with the chopper and feed it into the tip. The flow rate here controls the velocity of what's happening, the velocity of the aspiration. And then you can see the nucleus rotates perfectly well because hydrodissection was properly done. Holding the nucleus, don't let it to wobble in the eye. Once you hold it well, remember the example of the steak, the fork. Here the fork is the phaco tip and the chopper is the knife, and it feeds the nucleus into the tip, so the flow is continuous and the aspiration is effective. Once you have good hydrodissection, usually the epinucleus and the cortex, most of the cortex comes out with the phacoemulsification. Once you go out, inject viscoelastic to inflate the bag, push the anterior vitreous backwards, and then with bimanual irrigation aspiration, you remove what is remaining of the cortex. Same technique, you go with the aspiration cannula into the equator, hold with little vacuum the cortex, then pull it to the center. Once you see it, you can increase the vacuum as much as you need once you are in the center. Switching hands helps you to reach any part of the capsular bag. You can try to vacuum clean some of the epithelial cells, but as I mentioned again before, it's the best and easiest way is to wash out any filaments or epithelial cells on the posterior capsule using the 27 gauge cannula and gentle jets of fluid. This is followed by filling the anterior chamber with viscoelastic as well as the bag. As I'm going to use a hydrophilic lens here, I'm enlarging the incision a bit from 2.2 to 2.4. And then the cannula in the side ports helps to fix the eye while I'm injecting the lens. And also it has another function to push the lens directly into the capsular bag so you don't have to dial or do extra unnecessary maneuvers. This is followed by irrigation aspiration of the viscoelastic or any remaining epithelial or cortical filaments. You can remove the viscoelastic from behind the lens. Once you remove most of the viscoelastic, as much as you can see, then you hydrate the wounds, the paracentesis and the main wound, with the 27 gauge cannula, the helium cannula, and then you inject the intracameral antibiotic. Another example, in soft cataracts, the rules of the Capsulorhexis applies. And in soft cataracts, instead of thinking of cracking the nucleus, doing all the maneuvers, we will convert all the contents of the bag into one amalgam, one mass, by hydrodissection, hydration of the whole contents. It may prolapse from the bag or it may not, but the whole idea is you get one mass, one soft mass that you don't need to crack. And with aspiration, as you can see in the screen, essentially it is, or only it is vacuum. The chopper helps to feed the tip. There is no actual cracking. You can see the vacuum is the only player here. There is no ultrasound needed. And this technique makes the soft cataract an easier cataract to deal with, even if you are a beginner, because you don't need to do maneuvers like cracking, because you cannot crack a soft nucleus. If you did good hydrodissection and hydration, everything comes out only with aspiration. The Phaco machine is a very good irrigation aspiration machine, and you are done with the case. So I hope this concludes my technique in basic phacoemulsification using topical anesthesia and vertical chopping. Thank you for your attention.